Um, Hi, everyone. Thank you all for joining us for today's Campus Research Colloquium. And it is my great pleasure to introduce Jeanette Ruiz from the Communications Department. Jeanette has been a campus scholar for a few years, just like myself. And it's always a pleasure to overlap with her. And I've been waiting to hear about her work. So I'm really happy to have her here. And instead of doing a long introduction, it is a tradition that we allow the speakers to talk about themselves in their own words, which is, of course, much more compelling than me reading a CV. So without further ado, I give Jeanette the mic. Thank you.
Thank you, Mariel, and thank you so much. It's a pleasure to be with everybody today. As I was saying earlier, I am a first-gen student, and I am a professor on this campus, many thanks to Dr. George Barnett, who's joining us today, who convinced me to go on and earn a PhD and think about teaching. So I'm grateful to him for all of the mentorship he's provided. He's also the reason I'm coming to you with this topic today, and I'll talk a little bit more about that in a moment. But I grew up in this area and did everything I could to get away from this area, and somehow managed to remain an Aggie, it seems like, for a lifetime now. But I'm in the Department of Communication, and I teach a variety of different courses. And as I mentioned, I'm always thrilled to work with our growing diverse body of students. I learn as much from them as I do from my wonderful colleagues. But I'm excited to come to you today to talk a little bit about this topic that I've been working on now for quite some time. So vaccine hesitancy, it's an ongoing challenge. And I'd like to start first by telling you a little bit about how I got started or became interested in vaccine hesitancy. I had had my only child when I was in grad school, and like many a new parent, I was anxious, apprehensive, quite honestly, terrified. And anyone who's filled a parenting role knows that there's a lot of judgment in parenting. So I sought out advice and tried to do as well as, parents try to do. But at the time, obtaining parenting information online was quite a new normal. There was a plethora of blogs and websites that catered to all things baby and all things parenting. And traditional media wasn't far behind in reporting new trends. And the trends at the time are important to share with you. So at the time, they were pointing towards organic and natural. And that meant that you aspired, for example, I'll just share with you the aspirations, many of which I did not meet, but the aspiration to childbirth without pain relief or surgery, that you exclusively breastfed, and then you grew your own organic fruits and vegetables that you were then required to appropriately cook and feed to your child at specific times, that toys, diapers, clothes were made out of natural and organic materials, that you then laundered in organic detergent that was both fragrance and dye-free. Of course, that you also aim to expose your child to a natural immunity against disease instead of filling up your baby with these toxic chemicals that were found in vaccines. So that gives you an idea of where I was coming from in terms of parenting trends, but also, in addition to having these wild expectations that I don't know if it's gotten better, I'm actually out of sorts now, but as a scientist myself, I wanted to trust the science when it came to childhood vaccines. But everything I was reading about childhood vaccinations did have me a little bit perplexed. And so one of the things that had me a little vexed was the vaccine schedule, which I've included here. If you take a look at it, it's pretty intense what we're doing. Rightfully so, one would argue, but as a new parent, pretty intense. And remember, we are now making decisions for someone else, a very beloved someone else. Unfortunately, when I reached out to my pediatrician about these growing concerns of mine, I was quickly dismissed, which didn't exactly inspire a lot of trust. And then I should add that this was also around the same time when the very famous Wakefield article on the vaccine and autism connection had just been retracted. There was certainly a rise in autism that we were trying to better understand. And so there was a lot of media attention, especially around this, because you had parents and celebrities. So I have Jenny McCartney here, who's one that's been very vocal, connecting autism to certain childhood vaccinations. So it wasn't a wonder that there was new concern for parents around childhood vaccines, especially since vaccines were working. And I say this because when as parents, or we'll talk more as individuals, we're not seeing the ravages, say, of polio or of measles or et cetera, because the vaccines have been effective at combating these diseases. We weren't connecting that effectiveness, but we were connecting vaccines to autism. Again, for the reasons I've stated already. But why was there such a connection for parents, childhood vaccines to autism? Well, as I'd mentioned, the media were covering quite frequently this supposed autism vaccine connection. Was it the hype from the retraction? Was it the celebrity attraction? We probably won't quite know for sure. But I should note that what we do know is that trained journalists, their job is to report the truth, and unbiased, as much as one can be unbiased, account of facts or events. And in this quest, reporters will try and present both sides of an issue. Now, this works okay when there's an actual debate, say a political difference of opinion. However, the vaccine autism debate was presenting science on the one hand against anecdotal experiences on the other. And what the media were doing were presenting these two sides as equal. Now, historically, there has been a vaccine hesitancy and anti-vaccine sentiment since there were vaccines. But this new influx of media coverage about this debate among science and personal experience really only exacerbated the problem. So this got me thinking, and again, as I mentioned, Dr. George Barnett said, hey, here's an opportunity. You're trained in PR, and from that PR training, I knew that the narrative is very persuasive. So people in general really struggle to make sense of data, particularly if the numbers are confusing or complex. So in addition to that, while we weren't in the era of questioning facts, not quite yet, we did understand that people digested facts based on lived experiences. And that's true today. We tend to vote, for example, on these lived experiences. So this brings me back to the power of the narrative. And the narrative as you're understanding it from within your own lived experiences. So when your neighbor is telling you that her daughter is now autistic because of the last set of vaccines she was given, and you've seen with your own eyes this child go from verbal to totally nonverbal. Well, it's compelling. And that narrative and that lived experience, even if it's someone else's, but one that you've been privy to, it stays with you regardless of what the facts are. So the complexity of the issue and its direct ties to media, of course, and communication strategy got me really interested in taking a more broader look or approach to vaccine hesitancy, specifically around childhood vaccines, which, in my opinion, again, as a new parent, presented an inherent set of problems listed here on this slide, and also most of which I've touched on briefly already. The way I kept going back to it is, if I was somewhat vaccine hesitant, even though as a UCD PhD student at the time, I had access to all of the research data, it made sense that other parents would be hesitant and that you would start to see a growing vaccine hesitancy among well-educated, high-income mothers, which is what we were seeing at the time. So before the pandemic, we had completed various studies that focused on understanding vaccine hesitancy, specifically regarding online information and social media. So for example, we examined what information someone would find online about childhood vaccines based on what search terms they used for their search. So if they used something like vaccines hurt or harmful, would they get something different from, say, vaccines help? We looked at what information could be found online about the HPV vaccine, which at the time was a fairly new childhood vaccine. So we were curious what was circulating online about that vaccine. We also assessed how the health information sources people rely on impact whether or not they accept vaccine conspiracies, which would come into play later on as well. We researched how influential social media users have an impact or not on how anti-vaccine information travels, and we looked at that specifically over Twitter. We also assessed what themes and opinions about childhood vaccines could be found on Twitter. And we also looked to identify vaccine communities that were online and where perhaps those online communities lived, if you will, in their physical locations or geolocations. But, you know, I'm very pragmatic, and what I love about this work is that it's very applied. And so what were the solutions? We were getting a lot of great information, but what were the solutions? And we learned quite a bit. And by we, I don't mean just me and my co-researchers, but all of the researchers who have been looking at this issue for quite some time. And in specific to communication in my field, we learned that people do trust their providers most. And so we knew that there needed to be better communication in this relationship. And again, I was a perfect example of how reaching out to my physician and sort of being dismissed did not inspire trust in what I was being sort of guided to do. So, but the reality is we were just scratching the surface. So it was clear, though, very early on, that vaccine hesitancy is a very complex issue, which I think makes it more interesting. But it's one that isn't stable even within an individual. So, for example, I may vaccinate, no problem against, say, tetanus, no hesitancy at all. But I may be more hesitant about vaccinating my kids, say, against rubella, something I'm not seeing on regularly, and maybe don't want to expose my kids to that, what's in a vaccine for the slight risk that my child could contract rubella, for example. So that leads us to COVID-19. We're in a global pandemic, a situation many of us have not experienced before. We now also had a sort of perfect storm that really allowed anti-vaxxers to get vaccine hesitant folks on board, if you will. You had a new way for people to think about facts, as many of you have experienced. You had a growing reliance on social media in this isolation and targeted news to gather information and important information. You had leadership proposing a growing distrust in the media and science, and you had a politicization of how to best approach combating the pandemic. I also like to talk a little bit about Operation Warp Speed, because for many, the leadership in charge of combating the pandemic at the time that Operation Warp Speed had begun, but really it was also an issue with the name of the Vaccine Development Task Force itself. So Operation Warp Speed was not reassuring. Professionally, we would probably call this a branding failure. People assumed that important steps were being missed or avoided in order to get a vaccine approved and out to market. This new situation needed practical information fast so that public health officials could start to consider best practices in a really new unknown, but with sort of similar things in play. So we got to work as quickly as we could at trying to better understand this new situation. But before I go further, I want to talk a little bit about the differences between anti-vax and vaccine hesitant. And a lot of the literature uses these terms to mean the same thing, but we've come to learn that there are some differences. So for example, vaccine refusal often involves a deeper political, cultural, and emotional foundation. And so it's difficult for people to overcome those. These individuals are often described as anti-vax, and they tend to convene in more insular communities, and these can be physical or online. Because of this, well, maybe because of this insularity, we don't really know why, but they're very resistant to change. And so misinformation is often promoted by these groups. And again, anti-vaccine propaganda or persuasive tactics, if you will, have dated back to more than a century since vaccines came to be. The same arguments appear time and time again, regardless of the vaccine or the situation. And I find that really interesting. The arguments tend to be that vaccine side effects are worse than the diseases they prevent, that vaccines introduce toxins or cause disease in otherwise healthy individuals, that mandatory vaccines infringe on civil liberties or religious beliefs, and that doctors are biased, and that they are biased because of conflicts that they might have in promoting vaccines to the public. So these views are currently being generated by those who oppose COVID-19 vaccines and vaccine mandates. More recently, online anti-vaccine activity has been linked to foreign disinformation campaigns. So there's a new player in town. And despite outsized media coverage, total vaccine refusal or anti-vax sentiment is much less common than vaccine hesitancy. So again, the media have helped kind of hype up the actual situation. So vaccine hesitancy, on the other hand, is, again, as I've mentioned before, much more complex, and it captures a wider range of motivations and concerns. So for some folks, hesitancy around vaccination is grounded in a lack of knowledge, a lack of confidence in the vaccines, or too much confidence in the ability to avoid disease. There is, as mentioned, a lack of trust in the medical establishment. And we see this mostly for minority groups for good reason. And others feel uncertain about vaccines, again, either due to real fears. So something like, say, a fear of needles, or some are fear medical settings, for example. And then there are concerns about the side effects, often because vaccines have been associated with illness. So as previously mentioned, reduced cases of disease actually lead to complacency. And this is another variant of vaccine hesitancy, where people don't vaccinate because they don't perceive the disease they're vaccinating against to be an actual threat, or they perceive the vaccine to be more of a threat than the disease they're being asked to vaccinate against. So finally, and probably significantly for COVID-19, vaccine hesitancy stems from a distrust or suspicion in the medical system itself. So as previously noted, with COVID-19, there's some concern that the vaccines were rushed, beliefs that corners were cut in vetting the vaccines, et cetera. But I should note that these subtypes are usually intertwined, and it results in a wide range of individual perspectives about vaccines. And so rather than a complete opposition to vaccination, vaccine hesitant individuals are just uncertain, and we can change their minds to accept vaccination with focused interventions that address the very varying concerns around vaccines. But I'm getting a little ahead of myself here. So with that information, let me describe the three most recent studies that focus on vaccine hesitancy and COVID-19. So the first study, at the time of this study, COVID-19 vaccines were barely in development. And we had information from public polling that indicated that vaccine uptake would be suboptimal once these vaccines became available. So we thought, okay, we need some formative research here to better understand what could potentially be weak vaccine intentions. And while I'm a big fan of big data and the information it provides, it can tell us a lot, it can't always get us to actual beliefs, attitudes, and intentions. So these next three studies that I'm sharing with you today, I'll rely on a nationwide surveys and that were done online. This particular one was quota sampling that looked to produce a US Census match sample that was representative of the nation with regard to region of residence, sex, and age. And unfortunately, our study confirmed the previous polling that suggested COVID-19 vaccine hesitancy would be a challenge. And so more than 1/3 of our respondents were either not likely to get a COVID vaccine or were unsure about doing so. Those who said they would not get vaccinated cited vaccine safety and effectiveness as their primary reasons. So not a big surprise there. The study, though, did give us a little bit more in terms of the demographic and health profiles of those who shared that they would be most hesitant about being vaccinated. So we found that men, older adults age 65 and over, and individuals with pre-existing conditions that made them most vulnerable to COVID-19 were more likely to accept a vaccine. Again, makes sense. Unfortunately, the health disparities present in the spread and treatment of COVID reflected what survey participants said they would do. So as we know, the pandemic has especially burdened the African American, Latino, and Native American communities. They account for a disproportionate number of COVID-19 cases and COVID-19 deaths. Respondents from these subpopulations reported less interest in getting vaccinated. They noted worries about vaccine safety and effectiveness. We know that there is a mistrust in medicine, science, and public health in these groups, and again, for historical reasons. Another issue is the existing healthcare disparities that arise from adverse social and economic conditions. So similarly, improvements in health, quite honestly, have not been distributed equally across racial, ethnic, and economic groups, and this is negatively impacting the social determinants of health for minority populations across the US. What we were surprised to find, though, was no real regional differences in COVID-19 vaccine intent. So for example, we had predicted that vaccination intentions would be greatest in the Northeast because at the time, they were really just being devastated at the time of the survey. What this says to us is that the coverage, so the media were actually doing a good job here, that the coverage of what was happening in the Northeast was being well understood by the public at large. The findings also suggest that, again, speaking of media, that traditional and social media were both playing a role in the development of vaccine hesitancy, at least for COVID-19. Political party identity was unrelated to knowledge about vaccinations, but was associated with people's appraisal of the seriousness of COVID-19 and, of course, anticipated COVID-19 vaccine uptake. So respondents who relied, for example, on the two primary liberal cable news sources, those folks reported being more likely than conservative Fox News viewers, for example, to say they'd get vaccinated. I should note, though, that a majority of respondents from both groups reported an inclination toward vaccination. I should note, too, here that the cross-sectional nature of the data don't provide for causal explication. It could be that individuals gravitate towards the cable news network that present a view on the pandemic or on the seriousness or the need for the vaccine that's already aligned with their opinions. And in terms of social media use, we found that individuals who turn to social media for pandemic news were less likely to anticipate getting vaccinated. But we believe that social media have a much more nuanced effect than what our survey was capable of assessing. So definitely some opportunity for future work there. The next study extended from the first, also an online census-based survey. And here we were just trying to get a better sense of who accepted COVID-19 conspiracies and to what effect. We were seeing that conspiracies around COVID-19 were more and more frequently talked about in the news. And so essentially, we were looking to assess the acceptance of COVID-19 conspiracies and how these beliefs might be associated with adherence to masking, social distancing, and hand washing guidelines. Let's see, what did I miss there? Okay, got that. So what we found was that COVID-19 conspiracies was quite widespread. And this was my first foray into looking at conspiracies in the United States in general. And it's a little disheartening to learn that a lot of the work being done is actually abroad in Europe. And they find Americans to be quite conspiratorial thinking. So I found that interesting and Might be something I touch on a little more later on, but the study also provided a clearer profile, again, of the demographics or the characteristics of people who are more predisposed to accepting conspiracies, in this case around COVID-19. So unlike, or I should say, like past studies, we didn't find a difference between women and men in terms of their acceptance of conspiracies. However, minorities were more likely to accept coronavirus conspiracies. And again, possibly this is due to the longstanding mistrust of the health establishment. So you could see how some folks were like, okay, I can see this being a conspiracy. We also replicated findings that more education makes individuals a little less vulnerable to conspiracies. And we and others also found that older age was associated with less COVID-19 conspiratorial thinking. Now, this effect has been attributed to people's reliance on higher quality media sources, but even after accounting for media use, older age had a significant inverse relationship to conspiracy belief acceptance. We also found that those who reported having had a diagnosis, and this diagnosis, respondents could report, for example, that they'd had a formal diagnosis or they suspected a diagnosis of infection. These folks were surprisingly more accepting of coronavirus conspiracy beliefs, which we just found to be fascinating. So again, the pandemic and the US response to it have become politicized, as mentioned before. And so it wasn't too surprising in that there were differences to some degree between Republicans and Democrats, or those who reported ascribing to one party or the other. And our finding was that Republicans accept a wide range of COVID-19 conspiracy beliefs. And that supports previous research that found political conservatives tend to be more accepting of conspiratorial beliefs. However, our results also show that Democrats are also susceptible to conspiracies that align with their own political agendas. One other surprising finding was that the news sources that respondents regularly turned to about COVID-19 really didn't have a big effect on their belief acceptance, their conspiratorial belief acceptance. Only more regular reliance on Fox News, local news, NPR, and Twitter were significantly related. This is in great contrast with earlier studies that found that those who relied on social media for news were more likely to believe in COVID-19 related conspiracies. So this was a true surprise finding. The only thing I can attribute this to is that there was quite a bit of backlash about how the major social media platforms were dealing with the ability for people to share conspiracies and misinformation and disinformation online. So it could be due to more effort by these social media platforms to remove or at least downgrade misleading information about COVID-19 and COVID-19 vaccines. What we did find was that Twitter use was significantly related to conspiracy belief acceptance, but the relationship was negative. So those of us familiar with academic Twitter can probably attest to why that might be, or have some experience as to why that might be. But although there are anti-vaccine communities on Twitter, as I've showed before, I've done some work there. A recent review of Twitter content found a great amount of science-based information circulating on Twitter as well. So those who reported higher local news viewership were also less likely to accept conspiracies. The only sort of conclusion I can draw there is that people might liken their local news to the national news, and the national news was doing a really good job of reporting what these conspiracies were and sort of trying to work to debunk them to some degree. Furthermore, those who, this is what we were worried about, and we did find this to be true, that those who believed COVID-19 conspiracies did report less adherence to hand washing, to masking, and social distancing. Unfortunately, those who perceive themselves to be most vulnerable to a serious COVID-19 illness might also be less likely to follow CDC infection prevention guidelines. So it's almost as if the greater the risks, the more inactive people become. So we do know that challenging COVID-19 conspiracy beliefs is going to be and will continue to be an ongoing and difficult process, because what we learned about repudiating conspiracy beliefs in general is that it's difficult because you can't repudiate a conspiracy, or how should I put this? A conspiracy cannot be falsified by the same people and institutions that are the main actors in the conspiracy. So what research has found, however, is that if partisan elites can be mobilized to correct these false beliefs, there's some potential there. I love this study that was done that looked at efforts to inoculate the public against misinformation could also be successful. So essentially getting to these potential beliefs in advance of them growing widely online or otherwise. And so resistance to conspiracy beliefs can be built essentially by monitoring the information environment and then looking at ways to refute these claims, usually incorrect claims about whatever it is we're trying to organize against before these conspiracies spread widely. Finally, at the time, very little was known about parents' willingness to vaccinate their children for COVID-19. We looked at specifically parents with a child 12 to 15 years old, which was sort of the next on the market at the time. We looked at predictors of COVID-19 hesitancy among parents, potential reasons for resisting the vaccine, and was there a correspondence between parents' intentions to vaccinate their child and the acceptance of the vaccine for themselves. So again, another online survey. Again, the vaccines had not been approved for this cohort at this time. And I should note here, however, that our sample was skewed, and we're still kind of trying to figure out how that happened, but it did skew white, upper income, and that's problematic, of course. What we did find was that nearly 3 in 10 respondents were hesitant to vaccinate their child against COVID-19. The multivariate analysis of these predictors suggested that the primary concerns, again, not surprising, is a poor understanding of how the vaccines would work. And there was a lot of discussion about these being a new type of vaccine, the mRNA, and there just really was a lack of understanding of how they were different and what these side effects might be. So there was a susceptibility to vaccine misinformation. And again, something we've seen with childhood vaccines before, people disregarded that there was potentially serious health consequences that could happen with COVID-19. So a sense of, we'll just do natural immunity or take our chances than to take our chances with the vaccine. Only 2 demographic variables contributed to prediction above and beyond this, so knowledge, attitudes, and beliefs. And that was education and political party orientation. So again, we found higher education, what had been shown by others and by us to predict pediatric COVID-19 vaccine intentions. Other studies have shown that conservative voters are more likely to refuse COVID-19 for themselves. And this is a pattern that extends to their decisions about vaccinating their child. So, but one bright spot here is that parents rarely referenced vaccine ineffectiveness as a reason for the hesitancy. So I feel like that's progress. But it is concerning that 1 in 4 parents did prefer that natural immunity, or that their child achieve immunity against COVID-19 through infection rather than vaccination. So as I mentioned before, there'd been little research on the question of whether parents would differentiate between the value of vaccination for themselves and their children. And we didn't experience that here. So respondents who wanted a vaccine for themselves intended to vaccinate their child, and parents who refused to vaccinate themselves were also refusing to vaccinate their child. So in summary, this is such a complex issue, which makes it really exciting for researchers, but so difficult for public health professionals, and then difficult for us trying to kind of ease our way out of a pandemic. But what we do know is that targeted communication strategies are much needed. And I think what we saw was a real push to get vaccines out to the public, which the media sort of jumped on as information, and that's their job, the news. But there wasn't a whole lot of targeted communication strategies for trying to address the different concerns that these varyingly wildly different communities were going to need to accept a new vaccine for themselves and for their kids. So we're also seeing quite a need for improved trust in public health, our public health institutions, the decisions that we're making, and scientific practice in general. And part of it is that we take for granted, especially as researchers and scientists, that people understand how science works. And so I'm constantly explaining to folks that when science gets it wrong, it wasn't that they were lying to you, it's that they learned more and were able to update what they learned. And so that doesn't seem to be trickling down to the majority of the public. We're seeing most recently, for example, a recall, the school board in San Francisco, because there's a lack of trust in our public institutions about doing the right thing, or quote unquote, following the science. And so we talk about following the science, but I have a feeling that that's a trend phrase that's going to need some further examination, because it's going to mean different things to different populations, especially as the fallout of this hopefully very soon end to the pandemic comes to be. But again, there's so much work to be done here, so many interesting ways of looking at this topic. And so excited again to get to see what's next in the pipeline, and hopeful that we can start to get things more under control. But thank you so much. I'm not used to this format. I'm used to the lecture format where I get questions in between. So I'm really happy to get a sense of what questions you might have for me.
Thank you so much for a wonderful talk. If you have questions, feel free to unmute yourselves or write them in the chat. Or raise your hand, Jeffrey, if you want to unmute.
Thank you very much. I've really enjoyed the talk. And I wondered if there are, so my first observation is that you mentioned that I think there was correlation between holding a certain belief about vaccines and hand washing and masking. And I wondered if there were masking conspiracy and hand hygiene conspiracy as well, or
yeah, no, so we didn't particularly look at that piece of it. We our study just wanted to know, hey, we took the top sort of conspiracies that were circulating at the time, and it wasn't around the masking issue that we're seeing now. That wasn't very prevalent at the time. It was more like they're trying to chip us for population control, and the 5G towers are, ruining our lives. I mean, so we took the top ones at the time and shared those with respondents and said, hey, like, where are you here in what you're thinking? And then based on whether or not you accept these things, how are you doing as far as these public health guidelines? And so it would be really interesting to try to get a sense of, do those match up now that we're in a situation where we know that that's potentially problematic? What's been difficult, and something I feel very comfortable sharing with this community because you all understand this process, but I don't know if I dealt with the pandemic by immersing myself in work. I mean, I had a teenager at home doing online schooling that I was primarily responsible for kind of enforcing. And so I just sort of buckled down and worked, but the process to get reviewed and to get published took forever. So there's so much more I would have liked to have done, but that process just was so long and overwhelming. I don't know if it's improved. But yeah, I have so many ideas of where we could take this, but concerned that by the time I get there, it's been done because someone got to it, got a reviewer to get to it much more quickly than my paper, for example. But yeah, I would argue, Jeffrey, that it's probably very likely that that's the case, especially with what we're seeing in media circles and information we're getting now.
Thank you. Lillian has her hand up, and then I'll read the question in the chat.
Hi, Lillian.
Hi, how are you?
Hi,
So
nice to
excellent
see
talk.
you.
I truly enjoy it, but I have actually two questions. One of them probably is, I'm very curious about the historical perspective in terms of if there have been any study done about, comparing as an example, the hesitancy today versus how it was like with the Spanish flu, because at that time there were no vaccines available. In between that, we got, Tuskegee and all other scandals that probably will a little bit put a little bit in question the trust that the people might have in biomedical research. But at the same time, those things happen, they were kind of closed chapters, historically speaking, decades ago. So, there are people in our generation that they would never experience those scandals. They didn't saw them in the newspaper first time ever. So, I was wondering that because it was for me very demoralizing when I read that report in CNN, that, in terms of the casualties with COVID versus the Spanish flu, and they were comparing that in terms of total population. So it was not that the numbers were now higher because we have more people. So anyway, that's my first question because I, have to give.
Yeah, I mean, we don't have, at least that I'm aware of, comparative studies, but what I could surmise just based on looking at communication all of these years is that we just didn't have the same access to information that we do now. So for example, in our field, we talk a lot about this theory that it's called mean world syndrome, for example, that we assume that the world is this terrible place because of the way information is provided to us on a nightly basis. And having worked in news, I can tell you if it bleeds, it leads, right? And so that's what we're interested in knowing about. And because of that interest, so I can't blame the media completely. They're giving us what they want. And because that's the interest, that's what we get first, and it's what we digest. And then we start to believe that all of the world is like this. So that the negative stuff is more impactful. And so we had a less literate public in that time. There would have been more word of mouth sort of communication happening. And so I'm really just making wild assumptions here, but I think that might have a lot to do with it. I don't know though, at the time, if there was a politicization too of the events, which is an unfortunate reality that we're in now. And because people have a more broader choice of what media they do use, then people can kind of confirm their own biases in terms of what information they get. And so I don't think that was very helpful either. So it didn't surprise me, quite honestly, after what I learned, especially diving into that conspiracy stuff, which was totally new for me and really interesting. So I'm definitely hoping I can dig into some of that a little bit more in the future. But yeah, Lillian, I couldn't give you a straight answer.
Yeah. I think my second question was a little bit in terms of accountability, how, because at the same time, there are things that are very factual with the situation with the pandemic. And again, it's kind of heartbreaking to see that people with the facts, they were not just, portraying them as they are, which fits back into the conspiracy theories and all that stuff. So I would look at the accountability, two ways. One side, the media that spread things that are not true, but at the same time, us as an academic and scientific community, how we can learn from this experience to know how to explain better our science to the lay public, So I think that accountability, I feel myself responsible that I need to do a better job after what I had seen, explaining what we do here in our kind of ivory tower in the lab.
Right.
So the people could trust us again.
Yeah, and this is actually also a really exciting area of opportunity, I think. And before the pandemic hit, there was a growing interest in the field of science communication. And Dr. Barnett can talk a little bit about that as he's done some work there. But there is a great need for us as scientists to do better about speaking to the lay person. And in this case, it's going to be reporters and journalists. So how do we reach them so that they understand what we're doing in a way that's useful to them? And very often we just need to understand each other's goals. And so I teach a class in strategic communication, and that's one of the things I talk to them very frequently about, that if you're writing a press release, it isn't just about, ooh, look at this exciting stuff I'm doing, but writing it in a way that the journalists can do their job with it. In other words, that we're helping them do their work so that they can better reflect the work that we're doing in a way that is more palatable for a larger audience. And remembering that, unfortunately, in my eyes, your average audience is reading at a 9th grade level. And so what we put out in our peer-reviewed journals is definitely not that. And so how do we communicate what we're finding in a way that's, as you pointed out, accountable to the expectations of what we want for society? So do we want to be understood, or as you said, do we just want to be up in this ivory tower for each other? But for me, it's always been of interest to have my work be applicable. And I think that I'm hopeful. I'm talking to many more scientists who are saying, you know, this really opened my eyes to kind of the damage that was done, not just to public health institutions, but to science in general, where people have a mistrust in what our goals are. And I would argue that there's some truth to that. You know, the way the system is set up for us as academics isn't one that really highly regards getting our information out to the broader public. Definitely there are some things that we can do, but I don't think that we'll be able to do so effectively until the system in which we operate in changes to accept that a little bit more.
Yeah, thank you.
Yeah,
Accept it and value it, right?
right,
It's
right.
valued at the university level.
Yeah.
Extremely important. I see questions in the chat. Rochelle, you have two. Do you want to ask them, or do you want me to read them?
I can ask them, sorry. Hi.
Hi, Rachel.
Hi, your research is so fascinating. And I guess I have two questions. So one is, what have you found to be the most effective measures to counteract misinformation or conspiracies? And I guess it's a two-part question. Does it vary according to the particular demographics that you said, like age, political affiliation, etc.? And then the second one is a more aspirational question. And that is, if you had an unlimited pool of funding and you could scale up what you were doing, what questions or specific research or ways or methodologies would you do differently? What would that allow you to do?
That's so I'll start with the first question. From just, again, back to my professional training, we already know what's needed. We already know that we do require strategic communication to differing publics with different needs. I mean, that's the reality. We've relied too long now on traditional media, which is still very powerful, and where people turn to often to just get it right on their own. And that's why I think, again, it's very important that how we disperse and communicate the information to the broader public could really use our help. But yes, there are differing concerns based on who the population is. So for example, time and again, we saw minority communities who just had a mistrust of government agencies, again, not for unknown reasons, for public health, again, historically problematic. And so those things aren't surprising, and those things aren't new or unknown to us. And so the fact that we didn't already target these populations differently is problematic. I'll give you an example. We looked at a little bit different from communication, but we and now I say we, but public health professionals look to say, give folks incentives to vaccinate. And these incentives were like, yo, you could potentially win this thing, or whatever that might be. But in minority communities who are often working poor or working class, the reality was that the vaccines do have side effects, and those sideline people. I was out a whole day after my second dose of just, I couldn't function. I was just tired. And there's a fear around, okay, if I get vaccinated, will I be able to work? And maybe doing very physical labor that requires energy and concentration for safety reasons. And those are the kinds of things we're not thinking about as public health professionals. How do I allow you time off work when you're in a position where that's not my reality, where I don't have paid time off to take care of myself or a family member getting the vaccine? So yeah, I'll risk getting sick instead of risk the known potential side effects of a vaccine, which seemed like no big deal to us because we could work from home, we could Zoom in, we could, take it a little bit easier, but that's not the reality for most people. And so I think that reaches back to targeting communication, absolutely. And we really do have the means for that now. With social media, we can absolutely reach particular segments of the population who we know are in particular communities online and do a better job of also, it's the message isn't just the message, or the channel, as I used to say, but who is providing the message. So in the conspiratory thinking research, we know that if the people who these folks trust come out and say, hey, we were wrong, or hey, you should vaccinate, that's going to be better coming from them, as opposed to the institutions that they're already not trusting. So we know these things, but it's always easier to know than to do, right? But in terms of, honestly, Rachel, I have just never, again, I'm sure all of you understand, thinking big picture, giant funding opportunities. I have so many different ideas. There's the ideas that are just interesting to me, and then there's the stuff that I think could be helpful. They don't always intertwine, although sometimes a little bit. So as I said, I really got into the conspiratory thinking part, especially when I learned that Americans are most susceptible. And that led me into a big dark hole of trying to understand why that is. And partially it's because in reality, our government has engaged in conspiracies. And so it's not too far-fetched that it's not something that would continue. And so it's not something totally far off from how we think about how our institutions work. So I think that's really interesting. I think I would like to do a little more nuanced approach to how can we, so we know we need to be more targeted and more strategic, but to what degree and to whom? Like, so who are we still missing? And how do we get there? It's so nuanced, the vaccine hesitancy part, because it's so complex. And as I mentioned before, I don't know that we'll ever reach the anti-vax folks, but I think there's a lot of missed opportunity with the vaccine hesitancy folks. So probably something around there. That's a good one. I don't have to think more about that. That's exciting.
Thank you so much. I see Sophie has a question. Do you want to ask it, Sophie?
Hi, Sophie. Oh, we might have lost her. Oh, there's Sophie.
No, she's here.
And she's got a new baby, so she knows what I'm talking about.
Yeah. In fact, a lot of the reasons, a lot of the trends that you were describing about what's recommended for young children and what new parents should do, actually, like I've heard a lot of, and that's only in the last couple of years. So that's still around.
Oh, well, yeah, there's a lot of pressure to be the perfect parent, and man, what I wouldn't give for that more laissez-faire parenting style at this point. Look.
Yeah, I was curious, in all of your research, did you find any successful, examples of successful targeted messaging toward groups that are vulnerable to mis and disinformation?
We in these studies, we didn't look at that. So I haven't really taken a dive into the specific messaging that might get someone to have a better understanding, partly because when I first started doing this work, it was just trying to get an understanding of A, what's out there, B, what would people get if they looked? And then C, where are these communities and can we target them? So so far, it's almost been kind of like mapping where to target as opposed to doing the actual targeting. And so, yeah, that would be an interesting next step since we do know quite a bit more. But again, it would in my opinion, it would have to be really specific messaging. And as I was sharing with my husband the night before, I was saying that's more difficult to do than we think, because people turn to various sources for things. And I think we could all do that. We can all be an example of that, of how someone might say, hey, check this out. I learned this from X source. And then you might try to verify that easily, because we have at the touch of our hands the ability to look at different sources, and whether those sources are vetted or not is another situation. But I think this has really changed the game in terms of information and what's official and what's public. What I do know is, as I shared at the beginning of the presentation, was we've always known that the narrative is so much more powerful. We love a story. We've been telling fables, right, since who knows how long, because they work. And yet, if you take a look at any of our professional public health information, it's all data and facts, and they might get a little exciting with an infographic, but other than that, it's just so specific to the data and facts that we're missing that personal connection, that element of tell me that narrative. And so you can see, for example, commercials that do that. You remember those, you remember the story, you remember the actors in it, and they're persuasive. And so I wish we would take that kind of process a little further with our public health communication. There was I can't recall I'm using the anti-smoking campaign as an example. There was an anti-smoking campaign that came out recently with some really targeted ads for the African-American community that showed, sort of provided these narratives of the tobacco companies want to target you because they don't care about you. And they use some really targeted, I mean, it stuck with me, right? Like, I'm like, oh, wow, yeah, I could see that. And kind of played into this conspiratorial thinking around public health has never really been on my side, but yeah, maybe this company isn't either. And so how am I being played by this company? And I thought they did a really good job with that. I don't have the numbers to back up to see if it was successful, but it certainly stood out to me. And so campaigns like that, I think, would be much more effective, where we are telling the story as opposed to just sharing the data, which is difficult for people to process.
Thank you. Yeah,
Sure.
that makes a lot of sense.
Thank you, Sophie. It's nice to see you.
Are there other questions? And we're here in the informal part of the program, so feel free to just jump in with a comment or other questions for Jeanette.
I actually have another comment. Something that, like that bothers me sometimes, but in other occasions, I know the value of that is that when influencers or celebrity take, a flag for something, that if it's something that benefits us, our messaging is great, but then when someone posts on Twitter or Instagram, someone that we know that is going to be noticed because it's an influencer or a celebrity, because it's in Hollywood or a singer, then sometimes they spread bad information. And then, we always have this situation, at least for me, like, why don't better just show up and, don't talk if they don't know what they're talking about. But at the same time, we know that they are very powerful if they are in our side. So how we can a little bit fill that gap of approaching them ahead of time before they get fed by a conspiracy.
Yeah, and I mean, it all goes back to that personal experience. aspect of it. And this is why I showed Jenny McCartney, and we used to talk a lot about her being what a waste, right, of information and resources and airtime and whatnot. But the reality was that she truly believed her child was now autistic because of the vaccines her son was given. And so I mean, it came out later that she cured her son from autism. So I'm not sure if he just was, you know, there's varying degrees of, you know, on the spectrum. So where he was, and maybe just early intervention we know is very helpful, but she sort of backtracked a little, but by then it's too late. And by then the story isn't as interesting and the media is not picking that up. And again, those of us who study media know that, right? When you have a flashy front headline, that's way more exciting. It's going to get a lot more press than that little tiny retraction on page C14 that happens. And so it's just the nature of the cycle of news. And I would argue that the influx of the 24-hour news cycle or cable news, it generated, I mean, there's only so much news that's of interest to a broader, larger public. And then what you have now is kind of akin to what you're talking to, but I think it's even more dangerous to have these talking heads. I call them the screaming news, these talking heads that it's not news, but it's couched as news because it's on a news network, but it's just people bloviating on there with their own opinions about stuff that's often misinformation or disinformation. It's completely false a lot of the times. And by the time that they go to correct it, it's not news. So it's not getting as much press and as much coverage. And so we definitely are in a situation that does, as I said, we do sort of like the bad news, if you will. And we do know that celebrities can really help a cause. And again, I think they don't really care until they're personally affected. And that's the case with most of us. You know, we can say the same thing about politicians having a broad reach, but really only coming into play when something personally affects them, that they can join an association or, throw some money at the problem. So that's just human nature. And unfortunately, these folks do have such a much broader and wider network, and also just the appeal of airtime that, someone like us will never have. So it is very frustrating. But I think that's difficult to manage, because just like I think they have a difficult time managing being at the top of their careers, it's difficult to know what's going to pop out next in terms of what are they going to say that's going to derail actual science, as opposed to the anecdotal evidence. But this is why I shared that experience with you at the beginning, that when someone says to you, look, this was my experience, and then you're kind of seeing glimpses of that. Mm-hmm. I mean, you can turn around and tell me that's not true, but then I'm looking at it. And so I think that's going to become more relevant as time goes on, instead of less than. I think that there has been this idea that because there's so much information available to us, that we're somehow detached, but we're not. That personal experience and that narrative that's close to you is so persuasive. So it's going to have to do a lot with our own circles of our own social networks, which have been obliterated with the pandemic. We're all in isolation. We see ourselves in these boxes for a specified, time frame, and then there's very little connection, and that's so important for support, as we've learned, but also for sharing information that we trust from trusted sources. So I think it's made the situation worse, if anything. Mm-hmm. Yeah, I don't think I answered your question, Lillian. It's really complex. And I mean, we can't make them do anything, really. Mm-hmm. We can try to get them on our side, but it's not usually very interesting. I mean, if we're trying to spout some scientific something or another, it's not usually very sexy. So there is that issue around science communication of how do we make something interesting to the broader public? And again, that's something that I think has a lot of, there's some potential there for some work. how do we get our work to be interesting to others and applicable? And I think part of that is being able to not only talk about our work in a way that's understandable, but also building a narrative around that work so that it's easily digestible and understandable.
And
Thank
there's
you.
also the layer of building trust,
Mhm.
right? Because I mean, you're talking about personal experiences, and of course that's extremely important. We all relate to that. We all relate to the anecdote, but it's very dangerous to then have a fight of anecdotes. But I know this, but I've seen that.
Mhm.
So how do we leverage the anecdote that is so powerful and use it for good? And whenever I've seen, well, I mean, typically I don't engage with people who are engaging in conspiration, but when I'm tempted to do it, I want to tell them, go and see what the doctors and the nurses are saying, because they are telling the anecdotes from the floor. But those social networks seem to be impenetrable.
Mhm.
So those messages that the nurses are screaming out and the doctors, the emergency room doctors are screaming out, they're not being heard, or at least that's my impression. And it's very frustrating. So how do you build trust so that people in those very close social networks have believed that we are not to be trusted as scientists, or we are not to be trusted as public health workers? How can we dismantle that so that they can listen to the people who are in the hospital treating the patients? Because that's compelling, right? Seeing
Right.
someone on
No,
a
right.
ventilator is compelling.
And Marielle, you make a good point, because in doing this work for so long, I did get to a point of like, just exasperation of, we're not going to reach these folks. But as I shared with you, there is a difference, right? There's the anti-vax, and then there's the vaccine hesitancy. So there is that group that is willing. And I think we can kind of think about this politically too. It's almost a little bit like there's the diehard party person on either side, and then there's that person that's malleable in the middle that each party is trying to get on their side. And I think we just keep telling the story, and I think we just keep trying. And I'll give you a story to kind of make this point. There was a woman who I had a friend who was very frustrated by her mother, who refused to get vaccinated and believed it was all this big conspiracy to sell pharma, right? They're just trying to sell vaccines to the public. They're trying something new on us. It's not something I'm interested. And we're seeing the stories in the paper and on the news. We couldn't even blame weird like social media networks on this one. She was seeing the frustration that we were seeing from frontline providers. And it took she had joined some meditation group that met over Zoom regularly. And she had been in this group for about, I don't know, a month and a half or so. And then after the meditation group ended and they had an opportunity to kind of chit chat a little bit. And one of the women broke down and just started crying and said, I'm an ER nurse. And I forgot where she was, super far away from my friend's mom, and said, I lost my X number of patient last night, and I was really rooting for this patient. And then they just started talking, and she started to say, look, these are my reservations. This is what I'm thinking. Like, what are your thoughts? And that nurse could have just said like, oh, forget it. You're crazy. Like, I don't even want to deal with you, which I understand that. But that nurse just said, let me tell you what I know. Let me tell you what I'm seeing. And this is what I recommend that you do. She got vaccinated the next day. And so even though her own doctor had said, you need to do this, you're at a risk, it took that moment, that time, that connection, that narrative, seeing this woman who now she knew, right? This was someone now in her social network who she had a bond with and a trust with that was very different. Say to her, look, this is what I do, and this is what I'm seeing, and this is what I recommend. And that was effective where nothing prior to that had been. So again, sharing my own experience with my physician. And I think it's really important that we recognize that we do trust physicians, and for the most part, and unfortunately physicians in their own systems are so overworked and overwhelmed with time constraints and the number of patients that they're unable to take those extra 5-10 minutes to say, hey, by the way, I noticed you're not vaccinated. Do you want to tell me why? Share your concerns with me. Let's talk about it, or bring in that stuff online that you've looked at and let's talk about it. Let me tell you what I know and what I've seen. But again, I almost blame the system that we've set up. Healthcare doesn't provide for that option of building the relationship and then taking the time with a patient that, it's not an emergency, but we might get them to change their mind about vaccinating. So it is very frustrating. And it's almost like, you keep repeating the same story to your kid and you're hoping that one adult or peer gets through. And that's kind of how I look at this situation. And I think that's how we're going to have to start approaching some aspects of science communication in general.
Yeah, absolutely. Thank you for that.
Yeah, no, of course. It is frustrating.
Yeah, no, it is frustrating. But as you said, it's a very complex situation, and
Right.
a lot starts in healthcare, and establishing this personal relationship with the doctor, with the nurse, is something that has been lost and is essential.
Right.
Yeah, I
How do
read
we
an
get back?
account from a doctor recently, and it was the same type of thing. So she had a patient who was not vaccinated, and they had already tried, and the patient was not getting vaccinated. But she opened up like, well, if you want to tell me why. And the patient essentially said, well, she said no at first, but then eventually she said, well, what will the others think about me?
Right.
And then the doctor said, the others don't need to know. And the patient opened her eyes like, they don't need to know. Okay, give me the jab. Because she was in that hesitant group of people. She was internally convinced that maybe she needed a vaccine, but all her people were going to judge her.
Right.
And when she realized that they did not need to know, that was what she needed. So
Well,
yeah,
it's so interesting. It's so individual. And I checked on the chat really quick, and Rosa makes a good point. In our community, for example, in the Latin community, there's a lot of emphasis on natural remedy. And if you're religious, around prayer, that God will see for us, and that, again, it's that tactic of individualized messaging that yes, God looks out for us, and that yes, these home remedies are going to be helpful at symptoms and whatnot, but it's not going to protect you from this new unknown disease. And again, it's having a respect for the fact that people don't think like us. And it's so, I can't believe I just said that, because I'm so obnoxious about it should be like this, but it's really opened up my eyes to this idea around respecting where people are coming from, which is difficult because you just sort of wonder like, oh gosh, I don't understand this. And we don't need to necessarily come to a full understanding, but we do need to understand it well enough so that we can address it. And again, it's those very direct concerns for very individualized reasons. And I think, as Lillian pointed out, like, how do we do that? And I think it's just continuing to listen and to have those conversations. And I would argue that that's even probably how we'll make some headway politically as well. I feel like we're so divided on issues that we can't even sit with each other to get an understanding of, well, why do you think that? Where are you coming from with that idea? We're at a loss with that because it's so easy to fall into our little bubbles and sort of stay there and be very comfortable. But I think what this has taught us is that, it's very comfortable, but it's potentially dangerous in a pandemic situation when we're trying to get people to comply for broader public health concerns, as opposed to our own individual health and safety, which now requires people to think of others. And that's also really difficult in a society like the United States that's very about the individual. aspirations, individual goals, and it's also about the individual. And we do lose sight of community and community needs. And unfortunately, when George and I were looking at this early on, we saw that people would say to us, you know what, let your child get vaccinated and let's see how they do. They can be the herd to protect my child. I won't expose my child to the potential side effects. And so that was extremely frustrating, because they were being honest of,
Yeah.
And so how do we get around that? So there are systemic issues that we've touched upon, but there's also just a way around the way our society's been established and built. And that's really difficult to sort of change. That's not going to happen overnight.
Yeah, absolutely. And a whole thing that you didn't touch on, but I'm assuming you think a lot about is, I mean, as scientists, we have this responsibility to communicate our science, especially if we're funded by federal money. I mean, it is a responsibility to communicate to the public and to speak up. But, and the farthest reach is in social media, unless you manage to get your voice in the New York Times or a place like that. But in general, the farthest reach is through Twitter or other social media platforms. But there are vicious attacks against scientists, especially women, especially minorities. And that makes you as a scientist not want to engage.
Absolutely.
And I'm sure that's another very ripe field of study. Like, how can we protect the scientists and allow the scientists to just keep telling the stories? Because you're right. I mean, that's a way to do it. Just don't give up. Just keep saying it, keep saying it, keep saying it.
But yeah, you bring up a really sort of a really important issue. I had a friend on Twitter recently actually share on her feed with us. She's a political science professor, and she talks a lot in her work about local politics, specifically around sheriffs. And some information got out about her, and she got completely doxxed online. Her kids were being followed at school. Like, it got really, really scary. And so now any opportunity she has, she'll get online and ask faculty who are doing a lot of the research to pay for, there are groups, there's like services where they can eliminate. So for example, if you were to look me up, you could probably find out how old I am, past residencies, phone numbers. It's really easy to find. And then if you're willing to pay, I mean, you can locate just about anything about someone. And so she's suggesting that faculty start engaging in using these services that protect them from people being able to find all this information out about you for this reason. And interestingly enough, I didn't think about it because I thought, oh, I don't deal with anything very controversial, but it seems like everything's controversial these days. And so we're so on opposite ends of things that you could potentially engage the wrong individual, and it can happen online. And then it's real easy to kind of get this mob mentality around that. But it's
I've seen nasty attacks toward math professors talking about math.
What are you math people doing?
Yeah, talking about math. I mean, talking about social justice in math, of course.
Oh, okay. Yeah.
It's controversial, but nothing about vaccines or anything. So yeah, it can be really bad. Okay, I'm monopolizing the conversation.
No, it's very interesting because it's so true. I mean, when we know that the response is to, as you say, keep sharing the information, I think we do have to be aware of the change in sort of what's acceptable. And maybe we do so in a way that we also protect ourselves so that we're not communicating at our expense. So yeah, something to consider.
Thank you. Anyone else? We hit the 4:30 mark. Of course, I'm happy to stay. It's a good conversation. But if people want to chat or finish the session.
Well, I hope that I can come back to you in another year or two with some updates, but at the slow rate of this process, I don't know.
I would love that. I would love that. And you shouldn't, I mean, the lack of reviewers and how slow the publishing processes should not deter you from sending things out. And yes, we have to
I mean,
wait.
I understand why. I mean, totally understandable. Been there, done that, have declined a review